Okay, welcome everyone to the leadership webinar, Making Sense of the Policies Behind Healthcare Reform. My name is Janine Hopkins. I'm a principal with Santis Health, and I'll be presenting the session today along with my colleague Dan Carbon, who's also a principal with Santis Health. And we have a great project team here helping us out. This is the second of two webinars this month, and it's really designed specifically for leaders in the primary care, mental health and addictions, community and home care sectors. And there's a lot of things that are unique about this series, but in particular, it's a collaboration among 5 associations that represent these sectors, namely the Ontario Community Support Association, Addictions and Mental Health Ontario, Canadian Mental Health Association, the Association of Ontario Health Centres, and the Association of Family Health Teams of Ontario. We wanted to allow for as high a number of participants as possible, so we're holding the same webinar for each of the sectors today. So there's one webinar for each of the groups. This webinar is the one for the AOHC and AFDO members. And I want to really, again, recognize the leadership of the CEOs and the associations for taking this on and providing us with such invaluable guidance. And some of your member organizations also provided advice along the way to make sure that the webinar series is as relevant as possible. So now I'm just going to talk about this first webinar is really, the first webinar really provided an overview of health policy and the health system in Canada and Ontario. It really was designed to give you foundational knowledge and to take a step back and understand the environments in which you operate. This second webinar will really build on that first webinar, but we're really going to look more closely, take a deeper dive into Ontario's health policy and political landscape, and really to take a look at the healthcare reforms that are underway and topics such as integration that are, of course, top of mind for you, that you're going to have to continue to pay attention to regardless of what the outcome of the election is or any changes in the political side. We're very mindful of the fact that Ontario is going to the polls very shortly, and this is a time of course, some uncertainty, but we're hoping that you come away feeling better prepared for whatever changes may occur, and that you have a better understanding of what your organizations can do as a system to advance positive solutions. So we'll be sharing information about the key players in the health policy ecosystem. These are the roles that are key regardless of whatever the government is. The faces may change, but the roles will remain. We'll also explore healthcare trends and challenges that all governments face and the likely direction that governments and planners will take going forward. And the last section is about what each of the 3 main political parties have either stated or signaled about how they will address these challenges. We'll talk about what is likely to continue and what are the things that may change and what that might mean for your organizations and sectors. And then we want to leave you with thoughts about how your organization can not only keep moving in an uncertain time, but actually actively participate and influence solutions on the ground in the system. I'm going to now briefly just go over the agenda and the logistics for the webinar. We've designed the agenda so it's a mix of presentations and discussion. You're going to hear a lot from us, but we really do encourage discussion. There are about 200 participants in the first series of webinars overall, and really we found the questions and discussions were extremely valuable. So we encourage you to think about and pose questions throughout at any time, but we will be answering them at 3 points throughout the 90 minutes together. So following this introduction, the agenda is really 3 sections. The first one is taking a closer look at the politics of Ontario healthcare, how policy is made. We're going to then talk about what are the big trends and system drivers in Ontario that any government and leaders need to pay attention to. And then we're going to look ahead and see what the political parties are actually saying that they're prioritizing, what their response might be, but more importantly, what you can do as leaders to respond. I'm just going to go over a few logistical things. If you have any technical questions or issues, please call Citrix. I will give you the toll-free number, but you do have this in your information package. So if you have any problems, call 1-888-259 1-888-259-8414. That's 1-888-259-8414, and reference your webinar ID. Also, you can always send us a message through chat. For the Q&A that will follow each of the sections on the agenda, we'll use the chat feature. And so the chat option is at the bottom of your control panel. So simply click on the plus sign that's next to the word chat. You'll be then able to enter your question or comment. We have team members here that are going through all of the questions that come in, and we're grouping them according to common themes and ideas, and we're going to do our best to answer as many questions as we can, but undoubtedly there'll be some questions we won't be able to get to. So I want to rest assured that we are collecting all the questions, and the associations will put together a Q&A with the full range of questions received following the webinars. And lastly, the webinars are being recorded, and they will be available on the websites of each of the associations for those who may have missed today's session. So with that, I am going to ask Dan to talk us through the first section of the agenda.
Thanks for that context, Janine. And it's a pretty exciting time for politics in Ontario. We're on the verge of a provincial election campaign, so it's really timely that we're able to discuss the role of politics in healthcare and how it impacts you. I'm going to start off my comments today with talking about it, providing a bit of an overview of the importance of healthcare as a ballot issue in provincial politics and the relationship between healthcare and electoral politics. We're then going to provide an overview of the three main political parties and the roles that their leaders and other elected officials play in the health portfolio, how those folks are relevant to you. When you're trying to advocate for change on behalf of your organization or your sector, it's really important that you're able to approach the elected officials in government in a way that appeals both to the broader philosophies of the party, but also recognizes the personal styles and perspectives of the individuals in decision-making roles. To put it simply, people matter and relationships matter when you're trying to change things. In a ministerial system as well, cabinet ministers are given huge latitude in the health portfolio to make decisions, even if those decisions are not in full alignment with the premier. And often in election campaigns, we get a little bit fixated on the personalities and the statements of the party leaders. But it's really important to keep in mind that it's just as relevant for the health sector to understand who's likely to become a Minister of Health in a new government as to understand who's going to be potentially premier after June 7th. We're also going to start by reviewing the key roles and personnel within the Ministry of Health. Last week in the webinar, Janine gave an introduction to the roles and responsibilities of the Ministry of Health and how the Ministry of Health civil service staff interact with key political staff and elected officials, and also with local health integration networks and health service providers. We're going to go a little bit deeper into some of the people occupying some of those roles in the Ministry of Health and their perspectives and kind of the constraints that they operate within. In many cases, it's the interplay between the premier, the premier's office, the Minister of Health, the Minister of Health's office, and those top civil servants in the Ministry of Health that really shape the major strategic decisions that are made by governments on healthcare. Sorry. You'll see from this the headlines in this chart that healthcare is inherently kind of political. These headlines go back over the past 4 years. Some of them are actually from the last election campaign in 2014. But the trend has remained pretty remarkably consistent over a number of decades. And that is that when you ask people about what matters in provincial politics, what are the issues that are most important to them and what influences their vote, they consistently report back two things as the top priorities: healthcare and the economy. And it's usually with healthcare identified as the number one priority and the economy second, although that dynamic tends to flip in times of economic stress or when people are concerned or when we're in a recession or things like that. The thing about healthcare that's often understood by political actors, however, is that governments don't win campaigns on healthcare, although they can certainly lose them on healthcare. Healthcare is, of course, the biggest thing that provincial governments do. It's almost half their budget. But more importantly than that, it's something that directly touches everyone's lives in profoundly emotional ways. And the dynamic is really contributes to a sense that each provincial election campaign becomes, in a way, almost a mini referendum on the incumbent government's performance on the health file. And you really saw this in 2003, when the last change in government, when widespread dissatisfaction with the Conservatives' handling of the health file under Premier Mike Harris was a catalyst in the election of new Premier Dalton McGuinty. And there's a question as to whether you're seeing this dynamic emerge again. As noted, healthcare is remarkably personal, and people's views are informed by not just what they see in the media on a daily basis, but by their direct personal experience and the experience of their loved ones and friends and families. Just to give one example, over 2.5 million Ontarians actually, experience the emergency room every year and go through it. Millions more would go there with their family members. So it's that kind of point of contact where they're experiencing directly the system, and they're hearing about that experience from their friends and families in primary care and home care in the hospital. Those experiences together help people, shape people's perspective about how the healthcare system is performing writ large, and importantly, about whether things are getting better or worse in the healthcare system. For the party in power, the job during an election campaign is to remind the public about all the wonderful investments they've made in healthcare and highlight how those investments are improving care. That's why if you pay a lot of attention over the next few weeks, the next 6 weeks, you're going to see the Premier going around talking about, highlighting new construction at Sick Kids, highlighting new construction at Trillium, new hospital beds, highlighting new long-term care beds that will be developed. The government's going to be trying to point to tangible things that people could really grasp onto to show as a sign that things are progressing in the healthcare system. The job of the opposition is essentially the inverse. They need to make the claim that government has broken the healthcare system and that the province needs a new hand on the tiller to fix things. And that's why right now you see both the NDP and the Conservatives talking so much about the issue of hospital overcrowding and hallway medicine. Some of you may have even seen election ads in recent days about these topics. Notably absent in these discussions around election time and healthcare are usually any concrete and detailed discussions of plans to fix the healthcare system. Former Prime Minister Kim Campbell is pretty famous for remarking that, quote, "an election is no time to discuss serious issues." And in healthcare, she's spot on. Opposition parties who may have very, very different views on how the healthcare system should be run will still usually confine themselves to general discussions about how they'll, quote, "fix the system and clean up the mess of the governing party" during the heat of an election campaign. While they're happy to talk about new investments they'd make in the system if elected, they generally shy away from raising bold or controversial ideas that could spook or alienate voters. For all the flaws in the Canadian healthcare system, as we talked about last week, Canadians generally think that the overall model is working quite well and is worth retaining. When it comes down to it, very few in the public are looking for massive disruptive change to the healthcare system, and the political discourse across all three main parties reflects that reality. So I just want to remind people that the election in Ontario is June 7th, 2018. We hope that all of you exercise your democratic rights and responsibilities and participate in that election, no matter your perspective on the issues. We're entering into somewhat of an election season. There will be municipal elections in the fall and federal elections next year. We talked about in the webinar last week that both the municipal and federal governments have an important role to play in healthcare too. So it'll be interesting to see how this new dynamic emerges. Just to kind of put things in perspective of where things stand, we've had for the past 15 years in Ontario a Liberal government, 3 majority terms of government, and then from the period from 2011 to 2014, a minority government. And so for those of you who might be new to politics or don't pay close attention, a majority government means that the party in power controls more than 50% of the seats in the legislature. They have almost complete control over both the executive and legislative arms of government and have pretty free rein to implement the government's agenda. In the case of a minority, which happened in 2011, the government party usually wins the majority of seats and controls the executive arms of government, but relies on the support of other parties to pass essential pieces of legislation such as the budget bill. Minority governments are by their very nature inherently unstable. They're dependent upon ongoing negotiations and trade-offs between parties. The platforms that parties may have run on may have to be scrapped in a minority government as they look to seek compromise and common ground with other parties to keep them in office. The average minority government in Canada lasts for about 18 months. So it's not a very stable form of government. The Liberal minority in 2011 lasted a bit longer, for almost 3 years. The reports now, and you've probably seen a lot of this in the media, is that the electorate is looking for significant change after 15 years of government. The Liberals, however, their re-election pitch is premised on the idea that they can offer change within the Liberal Party, that by putting forward bold new ideas, particularly through the last budget and through their new election platform, advancing a progressive vision for the province, that they can sell to the voters that there can be change that they need within while keeping the Liberal government. The Progressive Conservatives obviously are promising fundamental change in a different direction, and the NDP is also responding to the public call for change by advancing ideas that they claim represent different fundamental differences from what the Progressive Conservatives and the Liberals would do in office. You as leaders in the sector and heads of organizations need to understand and prepare for political change. However, as Janine is really going to talk about later, the trends and realities that impact healthcare transcend the day-to-day political ideologies and debates. And the basic undercurrents of change in healthcare are ones that governments of any stripe are going to need to tackle. And you need to keep that in mind through the often heated rhetoric of election campaigns. And you also probably want to keep in mind that Ontario, throughout the past several decades of healthcare change, no matter which government has been in power, has tended to favor incremental change over big bang change. And that really has been something that's been quite different in Ontario if you compare us to the situation in places like the UK, where they favored very, very dramatic swings in healthcare, depending on who's been in government, and sometimes even within the same government. The other thing I wanted to note is that there's a fluid environment, and you might look at the polls and think the election outcome is predetermined. But not just in Ontario, but across the Western world, we've seen huge electoral volatility over the past 5 to 10 years. And the reality is that 6 weeks out from an election, no one can fully predict the outcome, and anyone that suggests they can is selling you a false bill of goods. No pollsters accurate, or very few pollsters accurately predicted the election of Donald Trump in the US. Very few accurately predicted the outcome of the Brexit vote. And the reality is, with 6 weeks to go in this campaign, it's very difficult to determine where things are going to land. Okay, on the next slide, we're just going to provide an overview of the key political players and their roles in each party. And regardless of who is in power, the responsibilities of the Premier and their relevance to the health system is that the Premier selects the Minister of Health, they set the mandate for the Ministry of Health, and they provide strategic oversight over the health portfolio. Many of you may have seen that the mandate letters that the premiers have given to ministers of health, outlining the key deliverables of the minister. In a way, you need to think of the Premier as like the boss of the Minister of Health. They set the performance expectations of what that minister will achieve, but they're not involved all the time in the day-to-day micromanagement of the healthcare portfolio. The Minister of Health, who currently for the Liberal government is Dr. Helena Jaczek, is responsible for the day-to-day strategic oversight of the ministry and accountable for ministry performance under the philosophy inherited from the Brits of responsible government. The Minister of Health is really the final decision maker at the Ministry of Health. Their signature is the last one on any funding package, on any letter, on any policy, on any regulatory change. The buck stops with the Minister of Health, as former president in the US, Harry Truman, used to say. Helena Jaczek has recently been appointed health minister and will only continue on in that portfolio if the Liberal government is re-elected and if the Premier chooses to continue her in that portfolio. There's often changes in ministerial portfolios after an election, although indications are that Jaczek, just a few months into the job, has been well received by the government, and there's a strong chance she would continue in the role. It's for the Progressive Conservatives, who are the official opposition. I think in official terms, they're Her Majesty's loyal opposition. The leader of the official opposition is Doug Ford, with the PC health critic Jeff Urich. Now, the role of the opposition is to really raise issues, to try and disrupt the government's agenda and shift public support away from the government. They also provide a really, really vital role in a democracy of providing a voice to those who see themselves shut out by the policies and priorities of the government, to bring to life those voices who might not be aligned with where the government is, and to continually challenge the government on how they're managing the system. In the next election campaign, Doug Ford has an interesting challenge in that he's running not just to become premier, but he's also running for the first time to get a seat in provincial parliament as a representative of Etobicoke North. Jeff Yurek, who's the PC health critic, was talked about for a long time as a potential future health minister, and that's is quite well regarded within the party. He's a pharmacist, a rural pharmacist, understands the healthcare system, interested in the healthcare system. It'll be interesting to see if the Progressive Conservative Party is elected, who they ultimately appoint as health minister, especially given the fact that former PC health critic, former Ontario patient ombudsman Christine Elliott, and former PC leadership candidate Christine Elliott is also running for the party, and many suggest that she would make a very, very strong health minister. As we mentioned before, and many of you would know Christine or had some interaction with her, as we mentioned before, who becomes the health minister is just as important to you as who becomes ultimately the premier in the new government. And last but not least, the NDP, which is currently the third party in Parliament. Andrea Horwath, the leader of the NDP since 2009, so she's very experienced. This is going to be her third election campaign after 2011 and 2014. When you ask people in Ontario who, their thoughts on party leadership, Horwath is generally the most popular of the three major party leaders. Her challenge has consistently been, since 2009, translating that general sense of likability and popularity into support at the ballot box, and translating that into support for NDP, the NDP as a government option. Franz Jelena, the NDP critic from Nickel Belt since 2007, is also is well respected within the healthcare sector. She worked within the CHC in Sudbury, Nickel Belt region before going into politics. Seems to have a very detailed and nuanced understanding of the healthcare system, and it's extremely likely that if the NDP were elected, and they'd want some, a knowledgeable, steady hand on in the health portfolio, that Franz Jelena would become the Minister of Health. Of course, all of those decisions are subject to ultimately up to the premier, and are shaped by a whole host of considerations, not just competency, but also regional representation, diversity at the cabinet table, other factors such as those. But these health critics play a key role in shaping the party's pitch on healthcare in the run-up to an election. We talked last week about the federal role in healthcare as well, and this federal government has played a much more active role in healthcare than the previous federal government under Stephen Harper. It's part of their, just in general, a more activist social policy agenda. In particular, you can see that the federal government playing a role in things like the Health Accord, but also key issues that require federal and provincial collaboration, such as the legalization of marijuana, addressing the opioid crisis, and medically assisted death. And these issues have required really complex, often sensitive discussions between the federal and provincial governments. And there has been in Ontario, an alignment, I guess, of philosophy and approach between the federal Liberal government and the provincial Liberal government. There's a question as to how that would change or evolve, those federal-provincial dynamics, if there's a new government in power in Ontario. But it is worth keeping in mind that throughout most of Ontario's history, the government in Ontario has been of a different political party than the government federally. And the thinking for a long period of time was that it was actually more beneficial to the province to have a government of a different stripe at the provincial level who could forcefully advocate for the interests of the province with the federal government, and not feel like they had to, in a way, pull their punches with the federal government. So it'll be interesting to see how this dynamic evolves. Okay. Now we're going to shift gears a little bit to understanding the civil service of the Ministry of Health and Long-Term Care. And for those of you following at home or at the office, you're going to see this very large, complex org chart from the Ministry of Health. And it's not, I don't think there's any intention that you can fully, you're going to digest this fully. There just on this chart alone, there are 94 executive roles identified in the org chart of the Ministry of Health. So it is, by any definition, a large and complex organization. And maybe that's understandable when you think about the fact that the Ministry of Health represents or is responsible for overseeing almost 50% of what the government spends on social programs, and that it's over $50 billion in expenditure every year. We just want to talk a little bit about the role and functionality of the Ministry of Health and how the model has evolved over time. So when LHINs were created, at the time LHINs were created, there was this was in 2004 or 5. So when I first came into the Ministry of Health, there were only 5 or 6 ADM portfolios, and they were very, very structured and focused on programmatic areas of responsibility. There was a hospitals branch, there's a home and community care branch, there's a long-term care branch, and a branch that focused on primary care, and then a kind of drug policy and public health branch. And those branches were filled with subject matter experts who understood the portfolios very well. With the advent of LHINs, the deputy minister and the Minister of Health at the time talked about how the expectation was that a lot of that subject matter expertise would shift to the LHINs, and the ministry would, in their words, rise to a more strategic level and focus more on a system stewardship role, where they'd be responsible for setting policy direction, standards, and oversight. And in many respects, they attempted to do that, and a lot of the subject matter expertise in the ministry, moved on to the LHINs or elsewhere. There was criticism for a while after that, however, that the ministry lost a lot of that subject matter expertise, that they didn't really understand the dynamics that hospitals were facing, that community care organizations were facing. So what you've seen in the last few years is that the ministry actually rebuilt a hospitals branch with subject matter experts who understand hospital funding models and can talk to the LHINs and health service providers on that. So you've seen the ministry evolve to try and have this stewardship role at the high level, responsible for policy direction and strategy and accountability, but also have subject matter expertise, which has led to, in part, this complex organizational structure. And I think you can kind of see that play out in how some of the key portfolios are organized within the Ministry of Health. Obviously, the key role within the ministry is the deputy minister, responsible for running the Ministry of Health, overseeing the policies for those thousands of people in the Ministry of Health, and responsible, along with the Minister of Health, for the overall health system performance. The way this deputy has chosen to organize things, given the complexity of the ministry, is to appoint 3 associate deputy ministers, each of whom have a number of assistant deputy ministers underneath them. These 3 associates really are responsible for the entirety of the health portfolios broken up between them. Now, and how it breaks down is a little bit confusing even to people who pay attention to a lot of this every day. So Laurel Taylor, her role is a little bit easier to define. It's focused very much on information technology, information management, and the kind of oversight of the e-health strategy. Where things get a little bit more confusing is between Sharon Lee Smith and Nancy Naylor. Sharon Lee Smith, notionally, her responsibility is for strategy, policy, and transformation, whereas Nancy is responsible for delivery, implementation, and accountability. But where things are a little bit interesting is that from a programmatic responsibility, they've kind of divided up some of the programs that the Ministry of Health provides into a more I wouldn't call it siloed way, but they've divided it up across the 2 portfolios. So Sharon Lee Smith has responsible for mental health and addictions, while Nancy Naylor has responsibility for the hospitals branch, home and community care, and primary care. And for you folks that are on this webinar, Phil Graham is the director of the primary care branch. He's the person who your associations would be directly interacting with probably the most. He would be the person who's expected to be the subject matter expert on primary care, who would understand the diversity of physician payment models and how these all interact, and the specific policy options that are available for the sector. So I just want to quickly kind of summarize this section by giving one example of this interplay between the civil service and the role that the civil service has and the political actors. And we're going to focus on, family health teams and the rollout of family health teams. So in 2004 or 5, when when the government was looking to introduce the family health team concept across the province, the civil service was tasked with undertaking a review to determine where there was the intersection of the greatest community need for new interprofessional primary care practices and effective capacity to be able to address that. So where were the groups that could pull together an effective family health team application, and where was that need? And the ministry provided that analysis and essentially a ranked list to the government with recommendations of where these family health teams should be located. But it's important to note that it's the Minister of Health who is responsible for signing off and making those decisions around family health teams. So the final decisions regarding which family health teams from that list were approved, when they were approved within the cycle, was taken by the Minister of Health, inevitably in consultation with his caucus colleagues, to understand what they saw as the communities that really had the most dire access challenges for primary care, where there was really a community need and uproar, where they needed a family health team put in place first. And it was that interplay between the technical expert advice of the civil service with the political acuity and connection to community provided by elected politicians who provide the democratic overlay that really resulted in the decisions about which family health teams were funded and when. Okay, I'm going to transition now to questions on this section. It doesn't look like we have any questions at the moment. So with that, I think what we're going to do is transition directly over to Janine, and anyone that does have any questions, that are kind of percolating, they can ask them and we can address them at the next section or at the end.
Thanks, Dan. So before I get into the specific health system trends and realities that impact primary care the most, I want to take a few minutes to really put health reform in a broader context. When you're in the middle of major changes and reforms, it can feel like the transformation is very new, that it's a brand new era. But the reality is, despite the rhetoric that you may hear, is that change is always constant. It may be the pace of change that's accelerated, but change is constant. And over the last number of decades, Ontario has tended to favor incremental change, as Dan was saying. We have not seen wholesale system changes that we've seen in other jurisdictions. And there's a remarkable level of consistency between the way in which the governments of different political stripes have addressed healthcare challenges. This may, in large part, because of we don't have a lot of latitude for reform, where our reform options are kind of constrained by our model of Medicare, by the Canada Health Act and other legislation, which really sets out what's funded by the public system and what the provinces are allowed to do. So Patients First is, of course, the current government's health reform plan, and you would be familiar with this and probably participate in a number of the initiatives under Patients First. But really, Patients First and the ideas in Patients First should be thought of as really the latest policy response to trends that have been with us for a long time. Some of the developments that I'm going to talk about shortly are more urgent today, but they're not brand new. So I'm going to highlight a couple of the milestones that really have led to where we are today. So some of you probably remember the district health councils. They were created back in 1974 by the Progressive Conservative government at the time. That was really the first policy move to really devolve planning to a more local level and to start to think about how to design services around the needs of geographic communities. The DHCs were planning and advisory bodies, but they really didn't have any power to make decisions or to really actively manage the healthcare system. Some of you may remember the Evans report in the late 1980s, and really that report was all about care integration and reducing silos between different parts of the system to create a better functioning healthcare system overall. I think it would be interesting to read that report, and I'm sure a lot of the ideas are still relevant today. The CCACs were created in 1996 under the Progressive Conservative government 20 years ago, and that was really a way to organize and standardize home care services and to also manage costs in the face of a growing seniors population requiring more care at home and in their communities. You may recall that there were at one point 42 CCACs, so home and community care was actually coordinated at a much more local level than it is today. That same year, the government of the day created the Health Services Restructuring Commission. And really, this was a response to mounting financial pressures on the healthcare system, and the government really made it a priority to deal with their debt. So the hospitals were the largest healthcare expenditure, and they felt that there was a lot of opportunity to rationalize hospitals. There was too much duplication, too many silos between the hospitals. So mergers were seen as a mechanism to create a more efficient system. But at the same time, there was also intended to be a push to deliver more care into the community, into home care, at the end of the HSRC's work, over 25 public hospitals had closed. This was a dramatic change, and it did result in some fundamental disruption, at least from a structural point of view. But there is questions whether this actually led to any fundamental changes in the way the healthcare system is delivered. And the longstanding critique is that the hospital restructuring was not accompanied by an investment in the development of services outside of hospitals, that is, community and primary care. So in 2006, the Liberal government created the LHINs, and that was really a move to more effectively manage the system at a local level. It was felt that the system was too unwieldy and too hard to manage centrally from one government. They wanted to follow the suit of other governments that had created regional health authorities. And they felt that the way to do this was to give providers and communities more accountability and role in creating healthcare solutions. Governance has always been a debate. It was a debate at the time the LHINs were created, and of course, in the LHIN model, the providers retain their boards. And the thinking was that the change needed to happen from strong top-down direction, but they also wanted to enable problem solving and accountability from the bottom up. Governance is still an ongoing topic of debate, and with the creation now of these subregions, which are in other, more local planning structures, the question will be how much control the LHINs will have over, the subregions and their priorities and how they actually coordinate and allocate funding for services, and how much accountability providers themselves will have within subregions for managing their very local healthcare systems. One trend, though, I want to flag is that there will be likely a continued move toward what we're calling shared or mutual accountability, where providers will be together accountable for delivering on a certain outcomes for their population. So you'll see things like MOUs between providers in a geographic area committing to a certain services and outcomes, and maybe even single accountability agreements where providers across the continuum will have one accountability agreement with the LHINs instead of separate accountability agreements. So I want to spend just a few minutes talking a little bit more about the Patients First plan. It builds on past reforms, as I said, but there are a number of unique aspects about it that are important to highlight. It's really built on 5 foundations. I'm just going to focus in on the few that are really most important to your sector. The first one that is really important is that the government has decided to devolve healthcare management to an even more local level with the creation of subregions. So the LHINs are responsible for creating these subregions, which are essentially networks of providers across all sectors that are responsible for providing care in a smaller geographic area than even the LHINs. So each LHIN will have somewhere in the range of 5 subregions, and they are the providers in those subregions are responsible for creating one plan for their area, coordinating services for the populations that receive care in their areas, and achieving common goals for the population served. And in these subregions, many of the LHINs have actually assigned formal leadership roles to different providers, including hospitals, community providers, and primary care leads. The second aspect proposal, I guess, in Patients First is the idea of creating better integration between home, community, and primary care at the local level. So the idea is that they need to be better connected to be able to actually take on a bigger role in healthcare delivery. And the other thing that is really important to bear in mind is the LHINs have actually taken on a more expanded mandate. This mandate will unfold, is expected to unfold in an incremental way, but they have taken on a significantly larger mandate. So with the merger of the CCACs into the LHINs, they're now not only planners or oversight bodies for home and community care, but they're actually directly delivering the home and community care services that used to be delivered by the CCAC. That's a big shift. They also have a role now in planning and oversight for primary care as a whole and making sure that primary care is connected with the rest of the services. That's a real challenge for the LHINs because, of course, they don't fund, as you know, or have authority over most primary care, including family health teams. Although they do, more and more you are seeing primary care coming to the table, and they want to find ways to incent primary care to come to the table. One of the ways to do that is to really use the care coordinators that are largely now part of the LHINs as a way to create that connectivity between primary care and other parts of the system in the community. So while the political situation is uncertain and may be volatile for some time, we shouldn't expect any major revolution in healthcare. Our healthcare model is deeply institutionalized and entrenched, and the public, there's no signs that the public wants any major disruption, but they do want improvements. So, you know, going forward, there may be differences in terms of whatever the future government decides it wants to fund. The level of funding increases we'll see, and this will be obviously significant for you. So we're going to talk a little later on, more specifically, about how your organizations can keep moving forward and not get stuck waiting for top-down direction, and how, in fact, when there are disruptive changes, you can actually look at that as an opportunity to put forward your solutions for what you think will improve patient care. So I'm now going to talk about some of the trends and realities that any government and any leader needs to take to pay attention to, things that transcend any one political party. So when there's a lot going on, it's important to understand, keep your eye on what are the most important trends. And so we're going to lay out what we think are some of the most important trends that will persist. The first one is a move to focus on outcomes, not just outputs. So historically, healthcare services were funded based on the number of activities or volumes provided. But we've realized as we get more and better evidence that providing more services or providing services using traditional models don't necessarily translate into better health outcomes for the population. Plus, funding activities is really, really hard to manage. The incentive when you're funding activity-based funding is really to provide more and more activities. So fee-for-service models, for example, the incentive is just to provide more activities, but not necessarily comprehensive care or better outcomes. So over time, there's been this move toward expecting outcomes, better outcomes for funding provided. And this shift goes hand in hand with having better data and a better ability to use evidence to assess whether what we're doing are the right things and they're actually improving people's health care and their experiences in healthcare. So the Excellent Care for All Act, which you may remember from 2010, really gave a basis for governments and LHINs and other funders. It really gave them the basis to stop paying for things that the evidence shows are either not improving quality or where we're paying too much for the outcomes we're getting. So one prominent example was vitamin D testing, where there was evidence, and really Health Quality Ontario advanced this, where there's evidence that there was regular vitamin D testing really did not lead to better outcomes in it, and the testing actually led to an overuse of vitamin D in the population taking vitamin D, which was not supported by the evidence. So that gave the government a basis to stop, delist and stop paying for vitamin D testing. Other examples of the shift to focus on outcomes are accountability agreements. So you've seen the LHIN accountability agreements slowly but steadily shift from being ensuring accountability for volumes and activities to, increasing accountability for actually meeting outcomes-oriented metrics. And one of the changes germane to primary care is this movement away from the fee-for-service model for physicians being paid on a capitation model. So the capitation model, where of course groups of physicians receive funding based on the number of patients, and the capitation approach is supposed to be an incentive to provide more comprehensive care rather than just episodic care. So I'm going to talk a little bit about funding reform in Ontario and what that really means for your sector. So there has been, the government has been undertaking a deliberate kind of reform around the way it funds healthcare based more on quality. So quality-based procedures was kind of a first step, and that was really funding for hospital services largely. But what they started to do with quality-based procedures was to provide funding to cover an entire episode of care. So when hip and knee replacements for both the surgical care through to the transition and the post-surgery rehab services. So in this case, the funding would go to one provider who would then share the funding with the other providers involved in that total episode of care, and that collectively the providers involved in that episode of care would be accountable for providing a standard outcome. This approach is now being used actually in the community sector for services that are provided collaboratively by hospitals and community and home care agencies together. So what we're seeing are groups of hospitals, home care agencies, and community agencies coming together and receiving funding to support a group of patients who are transitioning from hospital back home and being stabilized at home. So that journey from hospital to home, and in these bundled care pilots, there's a number of pilots that are underway, are really designed to help transition patients back home, but also to help keep them home to reduce readmission rates and pressures on hospitals. And there's some thinking that the LHINs will want to move to actually standardizing the way they pay for certain community and mental health and other services in the community. So they may move to actually selecting specific services and expecting common outcomes for a common level of payment for certain services. So they may pay one provider or group of providers to provide a certain service at a uniform standard at a uniform price. And they're going to choose, if they move forward on this, they will select services where there is a lot of variability in terms of what the LHINs are paying from one agency to another, and where there are clear gaps in terms of populations getting access to these services. The next trend I want to touch on is cost containment and efficiency, and we talked quite a bit about this in the first webinar, but I want to dig a little deeper into this. Ontario has really made it a deliberate decision to constrain healthcare spending in the last 8 years or so. Increases have been around 2%, which is just keeping pace with inflation. And of course, at that time, demand has been continued to grow. And so the funding has not really kept pace with the true demand and needs of the healthcare system. This is the graph here is from 2015, but it shows that Ontario, in fact, had the lowest per capita spending in healthcare of any of the provinces, or among the lowest anyway. There have been, though, significant moves to invest in community and primary care as a way to not only improve outcomes, but actually to reduce costs. So over the last number of years, there has been an investment in these sectors as a whole in the range of about a 6% increase. But Of course, as you know, has not been in recent years base funding increases to community and primary care. The increases that have been made to these sectors have been made for new services or to expand, to create new programs and new models. The funding has not gone to meet the current rising demand or to address the operational efficiencies that all of your organizations are feeling. And also the investments have probably not been sufficient to meet the influx of people, individuals who are now receiving care in the community rather than in hospitals. So in many ways, necessity has been the mother of invention in the healthcare system and in community and primary care in particular. The fact that there have not been any major reductions in services is because your organizations have been very creative in your efforts to operate as efficiently as possible as individual organizations. And also at the same time, governments, LHINs, providers, you've been working together to make significant changes in the way services are organized and delivered. That we see more sharing of resources across organizations, joining together, organizations deciding to join with others who have different kinds of capacities that they need, and leveraging others' infrastructures. We're seeing more team-based care delivery models. And it is becoming obvious to everyone that we've probably reached a breaking point in terms of individual organizations finding enough efficiencies from within. And in fact, community agencies, if you're any leaner, many would be unable to operate, and we'd start to see significant impacts on client care. The Provincial Financial Accountability Office recently released a report actually that said that the funding in Ontario has not been keeping pace with demand, and that soon we could see impacts on quality of care if it's not addressed. So it is no wonder that the government in its recent budget did announce significant increases in healthcare funding for hospitals and also the community sector, and most interestingly, perhaps the first base funding increase in some time to really addressing the pent-up demand and pressures across the system. But despite this funding increase to the healthcare sector and this increase in base funding for all organizations, we don't expect the funding levels would go back to where they were perhaps in sometime in the 80s and into parts of the 90s. The most, I think, significant trend that will endure is the fact that everyone realizes, every provider realizes really that they're not able to meet the needs of the population by acting alone, and that increasingly providers will need to share resources and find ways to collaborate and integrate the care that they deliver. And it is also clear that we will rely on a coordinated primary care and community care system, and that's the only way we're going to be able to improve population health as well as have a financially sustainable system. The third trend is really that we're going to see then is this continued shift of care out of hospitals and institutions and into community and primary care. Some may wonder if this trend is going to continue because there's been a big focus, obviously, in the media lately on hospital overcrowding, and there's been a lot of high-profile announcements about hospital funding. But I think, as we had talked about in the first webinar, it's probably more of a symptom that the government realizes that they may have squeezed hospitals too much. Hospitals have had years of pretty much flatline funding, and so the government's really trying to recalibrate things so that they don't see the quality of care in hospitals deteriorate. But I don't think anyone thinks that this is going to dramatically alter the course of reform. The focus will still be on strengthening care outside of hospitals, including home, community, primary care, and long-term care. It is important actually to flag that hospitals themselves are taking a leadership role in shifting more care into the community. They know that the key to sustainability is having more care in the community, and that's what patients and clients want. Hospitals do have the infrastructure and the capacity to support coordinated care networks, and so one of the examples is Sinai Health System here in Toronto has taken on a lead role in terms of creating an integrated health system, as has St. Joe's Hospital in Hamilton. So they've done this by leading a plan, but also merging with rehab, acquiring home care providers, and integrating with primary care. There is a debate around whether hospitals are best positioned to create or play a leadership role in creating these integrated community-based services. And I think there's also a thought among some that the best results will really come from community primary care and hospitals co-leading and co-creating these interconnected systems of care. What the hospitals bring is infrastructure and expertise, and what community brings is obvious, and primary care brings is their deep knowledge of the community and clients and their understanding of the social determinants of health and how to work with all of the different parts of society that impact people's health. And so this is the approach that's happening more in the subregions, where the different sectors are co-creating and working together, and there's not one sector that's playing necessarily a leadership role. The next trend is this shift toward decisions being based on data and incorporation of digital health into healthcare delivery. So obviously having good information, having information systems that are interconnected so that we can share client information, plan, improve performance, those are all foundational to a high-performing healthcare system. Ontario has had a mixed experience so far with digital health. On the plus side, within sectors, there's been investments and a lot of innovation. The LHINs have driven some initiatives to link up data between sectors. And there's certainly, we have a much better ability to not only gather data to understand the needs of the population, but to understand health services, but really an ability to do that at a very local level now with the subregions. EMR adoption within primary care has been a success in Ontario, and the vast majority of primary care practitioners use some sort of an EMR. But what we still don't have is largely an ability to share patient and client records seamlessly and continuously across sectors and providers. It's really difficult to link information across a system to manage care across a continuum of care. And we're also behind on engaging clients and patients in the use of these digital health technologies. One of the examples or the metaphors that's used for how siloed digital health is from the point of view of patients is the number of patient portals. So a number of hospitals have created these portals with the idea of providing their patients with one place to go to get their health information. But it's not unusual for patients to have access to multiple portals, each of which give them a little bit of information, a slice of information about their healthcare with one institution. They don't have one place to go to get all of that information together. So in reality, many patients aren't using these portals. They find them too confusing, too unwieldy, and too fragmented. The next trend is this emphasis on population health, and this is really positive for development for community and primary care, because of course you have taken a leadership role. In fact, CHCs, your model is based on addressing the social determinants of health. So what this really means with population health means is looking at how to improve the status of an entire population, and also looking at how to reduce inequities in access and outcomes among different groups in the population. In the past, it has been hard to get traction and investment in preventative healthcare or community healthcare, let alone the social determinants of health, because it's been hard to prove that if you invest in these things, if you invest in prevention and upstream, that you're actually going to automatically get better outcomes and cost savings downstream. People may know that intuitively and at a macro level, but it's been hard to say that if you invest in service A, preventive service A, you're going to get a downstream impact. But now with the better interconnected data, we have a ability to show cause and effect, and so we're going to have a better basis to actually make a business case for investing in population health solutions. The last one is a big one. The last theme is really the trend of integration, and we know that's top of mind for all providers. When we talk about integration, it means a lot of things to a lot of different people. And what we're going to do is really talk about what integration means in Ontario and how it's evolved and what it means for you. But basically, it's fair to say that there's interest, but there's, excuse me, a lot of confusion and some consternation about integration. All health systems around the world really have had to address integration in one way or another. And quite simply, it's because no one part of the system can provide all of what people need alone. And Ontario realized that, you know, while people have good experiences in the quality of service within each individual organization, with each service is really high, it's the movement between the services, it's the care transitions that don't work as well. And that's where there's the greatest dissatisfaction among clients and the population. So Ontario has put integration front and center as the mechanism to achieve better quality and a seamless experience, as well as a more cost-effective system. The LHINs were the model to create that system, so to create a system out of what has been separate sectors and individual providers. And with the patient's first strategy, there's an emphasis on integration, so an emphasis on connectivity between primary care and community and home, between home care, bringing together home care and all of the community support services that people need in their homes, in communities. And also the focus has been on better connectivity between health and the non-health parts of healthcare, the non-health providers that actually impact social determinants. So a better connectivity with municipalities, with social service providers and the like. What's really important to understand when you're thinking about integration is integration in Ontario was never meant to be the outcome. The goal was not to integrate, but rather it's a means. Integration should be seen as one strategy among other strategies. And the other thing that you really need to consider is that it's not likely that Ontario is going to put the brakes on integration anytime soon. The question is rather how integration will be driven, how much of it will be top down, how much freedom providers will have from the bottom up to integrate, and at what speed and intensity integration will occur. So your associations have actually taken quite a leadership role in defining what they think integration should mean, and the Community Health Ontario, which is the kind of an umbrella group that brings together a number of the community associations, put out a position paper where the emphasis should be on how you create an integrated experience for clients. At the end of the day, the goal should be what is the experience, what are the outcomes for clients. So there's a paper on integration. If you haven't read it, I encourage you to read it. But integration is not just one thing. There's many types of activities that could be considered integrative activity. There's, of course, vertical integration, which means integrating different types and levels of services. So primary care, integrating in some way with community support services and home care. There is horizontal integration. That's when providers of the same sector integrate together in some way. There's interdisciplinary care teams, shared care models that are integrative activities. There's actually joining together of clinical programs or back office consolidation where multiple providers use the same back office services. That's a form of integration. And the movement towards standardizing pathways or standardizing approaches, whether that's using common assessment tools or in fact or common guidelines, are all can be considered integration. And of course, resource sharing, things like hubs, things like shared training or shared spaces, co-locations, are forms of integrative activity. The next, this is a very helpful diagram that was created through a report that was done by the Toronto Central LHIN. So they, in 2016, they undertook a review and created a framework and a toolkit for integration in their LHIN. And this report was created by Optimus, a consulting group. So when people think of integration, they often jump to its mergers and structural integrations. And of course, full mergers and structural integrations are one type of integration and do have a purpose. but there's a whole continuum of activities. And so on the left side, it can range from informal networks or one-time arrangements to more formalized agreements, to creating standardized pathways, to full mergers and amalgamations. And the regional health authorities that are in some other provinces are kind of more of a full mature model, if you will, of integration, where there's actually one provider with one board, one governance structure. Many of you are actually, whether you consider it or not, are participating in integrative activity all the time. But you also need to look at whether you should more formally pursue integration. When you're thinking about integration, it's important to start by being really clear on what your objectives are. What are you trying to achieve? Because form should follow function. It may be that you're seeking greater financial sustainability. It may be that you lack capacity in some areas that other providers have. You may not have a strength in IT, or you need some other kind of infrastructure and need to join together with some or contract those services out. You want to maybe offer a broader array of services to your clients and need to integrate to do that. So there's lots of integration activity that's happening on the ground that's led by providers, but there's some of it that will need some support by the LHIN and others. I'm just going to provide a couple of examples of what this move toward integrating service delivery on kind of a more regional or local level. These are just 3 examples. The first one is the Sinai Health System. So this is where a hospital actually took a lead role in terms of creating an integrated care system for a particular population of clients. So really complex seniors are the population served. So what Sinai did is they actually acquired a home care provider. There was a merger with Bridgepoint, a rehab hospital, and through that they were able to offer an integrated acute rehab, home care, home and community care, as well as family health teams to their patients. The second one is the Muskoka and Area Health System Transformation Initiative. So this was really initiated prior to the subregions, but it actually is a partnership that covers a subregional area in the NSM LHIN. So the LHIN created a council that brought together not only healthcare providers, but municipal leaders, social and community services providers, all to one table to come up with a single plan for providing services to the populations living in the Muskoka and area. So including Bracebridge and Huntsville. This was very ambitious, and the work that was created and the partnerships that were created will be key to developing and actually a more formalized integrated healthcare system in that region. The subregion really has had a head start because of the planning that this group has done. And the last one is the government, of course, of the day is interested in hubs. So quite simply, this is the whole idea of making it easier for people to get populations to get what they need in one stop. Some of this is one-stop shopping, but sometimes it is the case of where a hub links services both physically but also virtually. So we're seeing different kind of hubs across Ontario. This is just one example where the government announced in 2017 integrated service hubs for youth that bring together both health services but also employment, housing, and social services in these one convenient locations across Ontario. So the last piece I want to leave you with is the LHIN's role in integration is really quite formalized and set out in their legislation, and that from the very beginning. And just the LHINs really have 3 ways in which they can advance integration. One is to use their funding to incent organizations to integrate services and to work in a more collaborative way. The second is they actually have power to facilitate and negotiate. They can be a lot more directive in integrations than they perhaps have been. Most of the integrations have been really the third area, number C here, which is voluntary integration. So that's where providers decide to integrate their services. In the case of voluntary integrations, the LHINs ultimately their boards need to review the proposals, the integration proposals, and they do have a decision-making authority. They can stop any integrations, voluntary integrations, if they don't think they're in the interest of the healthcare system or clients. And also for voluntary integration, some LHINs have helped them along by providing some seed funding, some guidance and tools to really help voluntary integrations. But now with the subregions, they're really going to be the focal point of integration. So across all LHINs, you're going to see more funding directed at kind of integrated solutions within these subregions. So the LHINs are, of course, moving away from providing funding to individual agencies for solutions, but they're funding collaborative solutions. They're saying we will only fund solutions that are collaboration among providers or across sectors, and actually will be flowing funding not just to single organizations, but groups of providers for a single solution. And the community, your organizations have a key role, of course, in creating those solutions, and we encourage you to continue to do that. It is possible that these networks, the subregions, might become even more formalized, and there actually may be individual providers who are tapped to play a leadership role in each of the subregions. So actually we'll be in charge of making sure that there is a coordinated care, and actually will be the recipients of funding directly from the LHIN to use to contract services from other providers in their areas. So these are a model called accountable care organizations, and you may see this actually emerge in the subregions. So I think with that, I am going to open it up for questions. I'm not sure if there's any that have come in. Yep, there have been some that have come in. Okay, so first one is, will you share the link to the position paper that the Community Health Ontario has put out? Yes, we will. We will definitely do that in the follow-up. And people asking if there's going to be reports after this. I believe there is a number of post-reading or supplementary documents that are going to be sent out that relate to what we presented here today. So we'll make sure that that position paper is included. But if there are other things that we've mentioned today that you're interested in, resources, we can certainly send links to those as well. Okay, any other questions? Okay, I think now I'm going to pass it over to Dan again.
Hey, thanks for that. I'm going to wrap up by giving us a little bit of a look forward and detailing what the three main political parties are advancing in terms of their healthcare agenda through the election campaign. As I talked about earlier, we're not expecting a detailed manifesto, a kind of soup to nuts guide of what the parties would do in election. It's more really talking about their priority areas of investment. It's often said that governing is fundamentally about making choices and accepting trade-offs, that, you know, if you pursue policy A, you can't necessarily pursue policy B. So the political party platforms in advance of an election are an important sign as to what those parties are identifying as priorities, and how they will respond to those kinds of challenges in the healthcare system that Janine talked about, that any political party will have to address after June 7th. So if we look at the Liberal Party, really the budget that was tabled at the end of March, the recent budget, should be seen as the basis of the political platform that the Liberals are really going to run for re-election on. It's important to note that many of the commitments that were identified in this 2018 budget would only really move forward in the case that the Liberal government is re-elected with a majority. So this is really, in a way, a communications document that really highlights what the Liberal government stands for, where they see as investment priorities going forward, and what they want to run for re-election on. It's very much a pre-election budget. It's an opportunity for the premier and for the party to showcase what they would do if re-elected. I think from a kind of macro level, the important thing for the sector is that there's a commitment to almost 5% annual increases in healthcare investment, and although, as Janine said, that's not necessarily the level that the sector would like, and it's not necessarily the level that's needed to sustain access in the face of growing demand. But it does mark a pretty significant departure from 1 to 2% investments over the past decade or so. And there's in particular significant investments highlighted for the hospital sector, for mental health, and for the home and community sector. There was nothing explicit in terms of new investment in the 2018 budget for primary care, and government sources report that was really because they put forward investments in the 2016 and 2017 budget that focused on primary care when there was almost no investment elsewhere in the system. There is some suggestion that there would be additional commitments related to primary care that would be advanced in the election platform that should be released any day now. Some other notable kind of commitments in the budget were a move through what the government refers to as the OHIP Plus program to eliminate the deductibles and co-pays for seniors. So like those under the age of 25, they would pay nothing for prescription drugs at the point of care. They're also advancing, for those people that are over 25 and under 65 are kind of left out by this expansion of the drug program. They've put forward a proposal for what they're calling the Ontario Drug and Dental Program, which would offer something like $400 for an individual and up to $700 for a family to cover costs related to drugs and dentistry, to in the Liberals' view, help ease the economic burden of people without any coverage at all. And moving on to the NDP, the NDP platform commitments related to health from a spending perspective are very, very close to that of the Liberal Party. They also talk about investment in hospitals and ensuring that hospital spending moves forward at least the inflation rate, and that in government they would address hospital overcrowding. They've also interestingly talked about placing a complete moratorium on the layoff of any healthcare professionals until a health system HR plan and capacity plan is developed. So we're not sure how that would roll out in detail, but they've signaled that they would like to see that any kind of transitions in that from the frontline staff would hold off until this plan is developed. Like the Liberals, they talk about expanded access to dental care and pharmacare. The NDP platform at a detail level is quite a bit different in that it would provide more universal access up front, but in the case of drugs for a much smaller list of products. So a broader base program that is not as deep is maybe the easiest way of understanding it. And the final major kind of interesting commitment that we've highlighted here is the creation of a unified mental health and addictions ministry. And there's been a lot of criticism over the past decade plus that mental health and addiction services are too fragmented and scattered between all kinds of different ministries: Ministry of Children and Youth Services, Social Services, Ministry of Health. So the NDP plan is to tackle that through creating a new mental health and addictions ministry. Again, very little detail about how that would actually roll out, and how they would create this ministry in a way not to ensure new silos between the Ministry of Health and this Ministry of Mental Health and Addiction. So they'd have to be very mindful of that challenge going forward if elected. And then finally, for the PC party, many of you might have seen when Patrick Brown was leader of the party, they put out a very glossy and quite detailed election platform called the People's Guarantee, and it included over 100 specific policy commitments. Quite a lot of those focused on healthcare. When Doug Ford replaced Patrick Brown as leader of the party, he essentially disavowed that party platform. He said that they wouldn't be moving forward with a cap and trade policy, for example. So it's really up in the air now as to how detailed the Progressive Conservative Party is going to be on the policy front. Are they going to release a platform at all? Most recently, they've been talking about just highlighting 5 key priorities if the party were to be elected in government, similar to what Stephen Harper did in 2006. Instead of a detailed policy manifesto or platform, just talking about 5 key kind of themes. But the party has been making some statements on healthcare. Doug Ford has weighed into the healthcare debate since being elected as party leader. And here are a few of the things that they've talked about, and these are admittedly quite vague. So you can draw your own conclusions as to what they mean if they were to form government pending the release of a more detailed policy platform. They've said things like, we're going to continue to provide help and resources to the healthcare system, and we're going to do that by listening to frontline workers. We're going to find efficiencies and better deliver services. Focus is going to be reducing hallway healthcare in hospitals and provide more timely access to care. And most recently, I think just earlier this week, Doug Ford mentioned that in terms of the opioid crisis, his government, if elected, would not favor funding for safe injection sites and really harm reduction approaches, but much more of a focus on providing treatment for people struggling with drug addictions. And that's really all we know at the moment from the Progressive Conservatives. While they're in this period between the previous platform that was developed by Patrick Brown as leader and seeing what Doug Ford kind of ultimately unveils in the election campaign. And with that, we'll kind of turn it over to any questions that people might have about the electoral dynamics, where the parties stand on healthcare, or what it means to you. You're a very quiet group. You're expecting that in 6 weeks from an election and the verge of a campaign, that people would have all kinds of questions about where parties stand on healthcare. But seeing none, I'm going to move on to kind of wrap up, which is, well, what can you do to stay ahead of the rapidly changing environment in the healthcare system? How can you respond to the uncertainty in the healthcare system as we're on the verge of an election? And the key message I think that we want to deliver to you is that you need to be proactively engaged. Particularly if there's a change in government, those who are coming in to run the healthcare portfolio will have zero experience in actively running the healthcare system. So although they might have broad policy ideas about what strategically needs to be done, in terms of how to implement change, they will be completely reliant upon the expert advice of not just the Ministry of Health, but those who on a day-to-day basis provide service in the healthcare system. And that by recognizing the influence and power you have as leaders and frontline providers, you can ensure that whoever is in government, that the policy directions that are ultimately chosen and implemented, where the rubber hits the road, really recognize the challenges at the front lines. So for you as leaders, you really need to understand this environment. And that's part of why you're engaged in this webinar series. You need to understand the evidence about the needs in your community and clearly define your value proposition. And as Janine mentioned, it's really important to collaborate and organize with others in your community to bring forward proactive solutions to those decision makers and influencers. It's really important that you know those people who are your local MPPs, as much as possible, the Minister of Health and their perspective, or who your associations will be dealing with. That your provincial association, of course, plays a key role at raising issues that you see in your community with the Ministry of Health and with those key provincial government actors. But the final message is really don't wait for things to change. There's a huge moment of opportunity, a window of opportunity when there's a new government, a new minister in power, where those who have their act together, have their message together, and have a compelling case for change are able to set and influence the agenda. So we're recommending that you're active participants in that process. Thank you for participating today.
Okay, so just to wrap things up here, this is Kathleen with the Leadership Project. Just thank you once again to Dan and Janine for another incredibly in-depth and valuable presentation. A note here, please take the time to fill out the evaluation that will pop up as soon as you close the webinar. We'll also email that link to you as well. We will use the results from these evaluations to inform selections of themes for upcoming leadership webinars. So please take the time to fill that out and let us know how you feel and think. The Leadership Project is ultimately concerned about delivering content to you that you're interested in and that can support you best in your roles as leaders in community and primary health care. You're also going to receive an email following the webinar with the slides, the recording, and a link to all the supplemental readings and documentation. So stay tuned for that. You may have also noticed that we launched our lovely new Leadership website this week on Monday. So go take a look over there at leadershipproject.ca. This is where you're going to find all of the latest project information, including links to the 2 health systems leaders webinars, and also links on how to apply to our upcoming cohorts that are being delivered province-wide of the LEADS 5-day learning series. That's an incredible opportunity, so don't miss it. We're still accepting applications for Ottawa, Mississauga, Timmins, Chatham, Hamilton, Kingston, Kitchener, and an additional French one happening in Ottawa. We're also going to be doing plenty more in the following fiscal year, and those locations and dates will be posted at the end of summer likely. Please also follow us at LeadershipON on Twitter, and this is where you'll get the most up-to-the-date information related to the project. Again, folks, thank you so much for your time. We know it's so valuable. Thank you for your engagement in this project. We truly appreciate it. Take care.